Hello there, and welcome to the Sleepy Science channel. Tonight, we'll be exploring one of nature's most remarkable creations, the human brain, and its incredible capacity for healing and adaptation after injury. This is a journey through resilience, through mystery, and through the profound ways our minds can recover and transform. Within the protective cradle of the skull lies an organ of extraordinary complexity, capable of thought, memory, emotion, and consciousness itself. Yet, it is also fragile, vulnerable to forces both sudden and subtle. A brain injury can arrive in an instant. A fall, a collision, a stroke in the quiet of sleep, or it can develop slowly, pressure building unseen, blood vessels weakening over years. The brain we carry is both our greatest strength and our most delicate possession. If you enjoy these quiet explorations of science and healing, I invite you to rest deeply, to let these words wash over you like gentle waves. There is no need to remember every detail, only to drift, to float, and to find peace in understanding. But for now, all you need to do is settle in, breathe slowly, and allow the calm of knowledge to carry you toward rest. Let's begin. The architecture of the brain. The human brain weighs approximately 3 pounds, yet it contains nearly everything that makes us who we are. Nestled within the skull's protective cavity, it floats gently in cerebrospinal fluid, cushioned against the jarring movements of daily life. This organ consists of approximately 86 billion neurons, each one a tiny processing unit connected to thousands of others, forming networks of staggering complexity. The brain's surface, the cortex, is folded into ridges and valleys, increasing its surface area without requiring a larger skull. These folds contain the centers for language, movement, sensation, memory, and reasoning. Beneath the cortex lie deeper structures: the hippocampus, keeper of memories; the amygdala, guardian of emotions; the thalamus, relay station for sensory information. Each region has evolved over millions of years, building layer upon layer of capability. The brainstem, most ancient of all, controls the fundamental rhythms of life: breathing, heartbeat, sleep, and waking. To understand brain injury is to first appreciate what an extraordinary structure we are discussing, a 3-pound universe capable of contemplating itself. When forces meet the brain injuries occur when external forces disrupt the brain's delicate functioning. The most common type is traumatic brain injury, or TBI, which happens when a sudden impact, jolt, or blow affects the head. Imagine a collision. The skull may stop moving instantly, but the brain, suspended in fluid, continues forward briefly before rebounding. This creates shearing forces, stretching and tearing the delicate connections between neurons. Even without a direct blow to the head, rapid acceleration or deceleration can cause injury. Soldiers exposed to blast waves, athletes experiencing whiplash, or passengers in car accidents may all sustain brain injuries through these mechanisms. The severity varies enormously. A mild traumatic brain injury, commonly called a concussion, may cause temporary confusion, headache, and sensitivity to light. A severe TBI can result in prolonged unconsciousness, significant bleeding within the skull, or widespread damage to brain tissue. Between these extremes lies a spectrum of injury, each case unique in its presentation and prognosis. The brain does not heal like other tissues. Neurons, once damaged or destroyed, rarely regenerate. Yet the brain possesses something perhaps more remarkable: plasticity, the ability to reorganize itself, to forge new pathways, to compensate for what has been lost. The moment of impact. In the instant of injury, Several processes begin simultaneously. The mechanical force damages neurons directly, tearing axons, the long fibers that transmit signals between brain cells. Blood vessels may rupture, causing bleeding within the brain or in the spaces surrounding it. The impact disrupts the blood-brain barrier, that selective filter that normally protects the brain from harmful substances circulating in the bloodstream. Chemical cascades are triggered as damaged cells release their contents. Excitatory neurotransmitters flood the spaces between neurons, overstimulating surrounding cells. Calcium rushes into neurons in quantities that would normally be tightly controlled, triggering destructive processes within the cells. Inflammation begins as the body's immune system responds to injury. While inflammation serves protective functions elsewhere in the body, in the confined space of the skull, swelling can be catastrophic. As brain tissue expands, pressure increases. Blood flow may be compromised. Neurons that survived the initial impact may now face a secondary injury from inadequate oxygen and nutrients. This is why immediate medical care matters so profoundly. The first hours after brain injury are critical, a window in which interventions can limit the cascade of secondary damage. Concussions. The invisible injury concussions represent the mildest form of traumatic brain injury, yet they are far from trivial. They occur when the brain experiences a sudden movement within the skull, causing temporary disruption of normal brain function. Unlike more severe injuries, concussions typically do not cause visible damage on brain scans. No bleeding, no skull fracture, no obvious lesion. Yet those who have experienced one know the symptoms are very real. Headache, dizziness, confusion, nausea, sensitivity to light and sound, difficulty concentrating, memory problems, and changes in mood. The hallmark of concussion is that these symptoms are temporary. With rest and proper management, most people recover fully within days to weeks. But recovery is not automatic. The brain needs time to heal, to restore its chemical balance, to repair damaged connections. Returning too quickly to activities that demand concentration or physical exertion can prolong symptoms or even worsen them. Athletes who sustain concussions face a particular challenge. The culture of toughness, the pressure to return to play, can conflict with the brain's need for rest. Medical protocols now emphasize graduated return to activity, ensuring that each stage of recovery is complete before moving to the next. The mystery of post-concussion syndrome. For most people, concussion symptoms resolve within weeks. But for some, symptoms persist for months or even years, a condition called post-concussion syndrome. The reasons for this prolonged recovery remain incompletely understood. Some researchers believe it results from ongoing metabolic disruption in the brain. Others point to the role of the vestibular system, the balance centers that may be damaged in concussion. Still others note that anxiety and depression, which commonly follow brain injury, may perpetuate symptoms. What is clear is that post-concussion syndrome is not psychological weakness or malingering. Brain imaging studies have revealed subtle but real changes in those with persistent symptoms. Functional connectivity between brain regions may be altered. Blood flow patterns may be disrupted. The brain's default mode network, active during rest and self-reflection, may function differently. Treatment approaches vary widely. Some focus on physical rehabilitation, gradually increasing activity to improve stamina and reduce symptoms. Others emphasize vestibular therapy to retrain the balance system. Cognitive rehabilitation can help with memory and concentration difficulties. Medications may address specific symptoms like headache or sleep disturbance. The path to recovery is often long, and requires patience from both patient and caregivers. Repetitive head impacts. A single concussion, properly managed, usually heals. But what happens when head impacts occur repeatedly over months or years? This question has gained urgent attention with the recognition of chronic traumatic encephalopathy, or CTE, a degenerative brain disease found in individuals with a history of repetitive brain trauma. First identified in boxers in the 1922 and called punch-drunk syndrome, CTE has more recently been discovered in American football players, hockey players, military veterans, and others exposed to repeated head impacts. CTE can only be definitively diagnosed after death through examination of brain tissue. The characteristic finding is an abnormal accumulation of tau protein, which forms tangled clumps inside neurons. These tangles are particularly prominent around blood vessels and in the depths of the brain's folds. As the disease progresses, affected individuals may experience memory loss, confusion, impaired judgment, impulse control problems, aggression, depression, and eventually, progressive dementia. Symptoms often don't appear until years or decades after the last head impact, making it difficult to establish clear cause and effect for any individual. The discovery of CTE has transformed how we think about contact sports and military service. It has prompted rule changes in youth sports, new helmet designs, protocols for concussion management, and debates about the acceptable level of risk. Yet much remains unknown. Why do some individuals with extensive exposure to head impacts never develop CTE, while others with seemingly modest exposure do? What role do genetics play? Is there a threshold number of impacts below which CTE doesn't develop? Can anything prevent or treat it? These questions drive ongoing research as scientists work to protect those at risk and help those already affected. The skull fracture. When the impact is severe enough, the skull itself may break. A skull fracture is a crack or break in one or more of the bones that form the protective case around the brain. Fractures can be simple linear cracks, like a line drawn on an eggshell. They can be depressed, where fragments of bone are pushed inward toward the brain. They can be comminuted, shattered into multiple pieces. Or they can be basilar, occurring at the base of the skull, where it meets the spine. The location and type of fracture matter greatly. A simple fracture at the top of the skull may heal on its own with minimal intervention. A depressed fracture may require surgery to elevate the bone fragments and prevent them from damaging underlying brain tissue. A basilar fracture is particularly concerning because it may tear the membranes surrounding the brain, allowing cerebrospinal fluid to leak from the nose or ears. This creates a pathway for infection, a dangerous complication. Signs of a basilar skull fracture include bruising around the eyes, a distinctive pattern called raccoon eyes, or bruising behind the ears, known as Battle's sign. Clear fluid draining from the nose or ears is another warning sign, indicating that the protective barriers around the brain have been breached. Treatment depends on the severity and location. Many skull fractures heal with observation alone, the bone knitting back together over weeks to months. More severe fractures may require surgery to repair the skull, control bleeding, or relieve pressure on the brain. Antibiotics may be given to prevent infection if the membranes have been torn. The presence of a skull fracture doesn't always correlate with the severity of brain injury. Someone can have a significant brain injury without any fracture, or a fracture with minimal brain injury. Each must be assessed independently. Bleeding within the skull. When blood vessels in or around the brain rupture, blood accumulates in spaces where it doesn't belong, creating dangerous pressure. There are several types of bleeding, each with its own characteristics. An epidural hematoma occurs when blood collects between the skull and the dura mater, the tough outer membrane, surrounding the brain. This often results from a tear in an artery, and because arterial blood is under high pressure, the hematoma can expand rapidly. The classic presentation is a person who initially loses consciousness briefly, then seems to recover, a period called the lucid interval, before deteriorating rapidly as the hematoma grows. A subdural hematoma forms between the dura mater and the brain itself. These often result from torn veins and may accumulate more slowly. In elderly individuals or those on blood-thinning medications, even minor head trauma can cause a subdural hematoma that expands gradually over days or weeks. Symptoms may be subtle at first: mild confusion, slight weakness, or personality changes that could easily be attributed to other causes. An intracerebral hemorrhage is bleeding within the brain tissue itself. This can result from trauma, but also from other causes like high blood pressure or abnormal blood vessels. Subarachnoid hemorrhage refers to bleeding in the space between the brain and the thin membranes closest to it, where cerebrospinal fluid normally circulates. All of these types of bleeding share a common danger. The skull is a rigid container with limited space. As blood accumulates, pressure rises, brain tissue is compressed, blood flow is impeded. Neurons begin to die from lack of oxygen. Urgent treatment is often required, ranging from medications to reduce swelling and seizures to emergency surgery to drain the blood and relieve pressure. The outcomes vary widely, depending on the size and location of the bleeding, how quickly it is treated, and the patient's overall health. Diffuse axonal injury. Some of the most devastating brain injuries leave no obvious sign on initial brain scans. Diffuse axonal injury, or DAI, occurs when the brain experiences rapid acceleration-deceleration forces that cause widespread tearing of axons throughout the brain. Axons are the long, cable-like extensions of neurons that transmit signals. They are delicate structures, and when subjected to shearing forces, they stretch and tear. Unlike a localized injury, where damage is confined to one area, DAI affects multiple brain regions simultaneously, disrupting the communication networks that allow the brain to function as an integrated whole. The clinical presentation of DAI is often severe and immediate: prolonged loss of consciousness, coma, or persistent vegetative state. Even when patients awaken, they often face profound cognitive and physical impairments. Memory may be severely affected, concentration and attention may be compromised. Personality changes are common. Physical disabilities may include weakness, coordination problems, or difficulty speaking. The microscopic nature of the damage makes it difficult to visualize on standard CT scans. MRI scans, particularly specialized sequences, looking for signs of blood or tissue shearing, may reveal small hemorrhages or abnormalities scattered throughout the brain's white matter. Recovery from DAI is prolonged and often incomplete. The brain must essentially rewire itself, finding new pathways to accomplish functions that were once automatic. Intensive rehabilitation over months to years may help patients regain some lost abilities, but the reality is that severe DAI often results in permanent disability. Families face enormous challenges as they adjust to caring for a loved one who may never fully return to their former self. The emotional toll is immense, a grief for the person who was, even as they work to support the person who remains. The spectrum of consciousness. One of the most profound aspects of brain injury is its effect on consciousness itself. The awareness, the sense of self, the experience of being awake and perceiving the world can all be disrupted. In the immediate aftermath of severe brain injury, patients may enter a coma, a state of complete unconsciousness from which they cannot be awakened. The eyes remain, closed. There is no response to painful stimuli. The person appears to be in a deep sleep from which they cannot be roused. Coma results from damage to the brainstem or widespread injury to both cerebral hemispheres. It represents a profound disruption of the systems that maintain wakefulness and awareness. Most comas don't last indefinitely. Over days to weeks, many patients begin to show signs of emerging consciousness. They may transition to a vegetative state, where the eyes open and close in sleep-wake cycles, but there is no evidence of awareness of self or environment. They may yawn, make sounds, or move reflexively, but these actions are automatic, not purposeful. The term vegetative is clinical, not intended to be dehumanizing, but families often find it deeply disturbing. More recently, the term unresponsive wakefulness syndrome has been proposed as an alternative. From the vegetative state, some patients progress to a minimally conscious state. Here, there are reproducible but inconsistent signs of awareness. The person may track objects with their eyes, reach for objects, or respond to commands sometimes, but not always. The boundaries between these states are not always clear, and misdiagnosis is disturbingly common. Studies using advanced brain imaging have revealed that some patients diagnosed as vegetative actually retain awareness, but cannot express it through movement or speech. They are essentially locked inside their own bodies, conscious but unable to communicate. This has led to the development of new assessment techniques using functional MRI or EEG to detect brain activity in response to commands. Even when patients cannot move, their brain activity may show that they are processing language and attempting to respond. These discoveries have profound implications for medical care, ethical decisions about life support, and our understanding of consciousness itself. Locked-in syndrome, perhaps the most haunting outcome of certain brain injuries, is locked-in syndrome, a condition in which a person is fully conscious and cognitively intact, but almost completely paralyzed, unable to speak or move anything except their eyes. This results from damage to specific pathways in the brainstem, the part of the brain that connects the cerebral hemispheres to the spinal cord. The damage interrupts the signals traveling from the brain to the body, but leaves the cerebral hemispheres, where consciousness resides, completely intact. The person can think, feel, hear, and see, but cannot respond in any conventional way. The experience is one of profound isolation. Imagine being fully aware of conversations happening around you, understanding every word, having thoughts and opinions and emotions, but being unable to speak, to gesture, to indicate in any way what you are thinking or feeling. For those newly locked in, the experience can be terrifying, a nightmare from which there is no waking. Communication is possible only through eye movements, blinking once for yes, twice for no, or looking at letters on a board to spell out words painstakingly slowly. With modern eye-tracking technology and computer interfaces, some locked-in individuals can communicate more efficiently, even writing books or essays about their experiences. What is perhaps most remarkable is that many people with locked-in syndrome report eventually adapting to their condition and finding meaning and even happiness in their lives. Studies of quality of life in locked-in individuals have found that while the condition is undeniably challenging, with appropriate support and assistive technology, many rate their quality of life surprisingly high. They maintain relationships, pursue intellectual interests, and find ways to contribute to their families and communities. Their experiences challenge our assumptions about what makes life worth living and remind us that consciousness and personhood persist even when the body's capacities are profoundly limited. Stroke. When blood flow stops. Not all brain injuries result from external trauma. Stroke, the sudden interruption of blood flow to part of the brain, is one of the leading causes of brain injury worldwide. Strokes come in two main varieties. Ischemic strokes, accounting for about 85% of all strokes, occur when a blood clot blocks a vessel supplying the brain. The blockage may form locally, in an artery narrowed by atherosclerosis, or it may travel from elsewhere, a clot formed in the heart that breaks loose and lodges in a brain artery. Hemorrhagic strokes occur when a blood vessel ruptures, spilling blood into the brain tissue or surrounding spaces. The symptoms of stroke depend on which part of the brain is affected. A stroke affecting the left hemisphere may cause weakness or paralysis on the right side of the body and difficulty with language. A stroke affecting the right hemisphere may cause left-sided weakness and problems with spatial awareness. Strokes in the brainstem can affect basic life functions. Strokes in the cerebellum may cause dizziness and coordination problems. The key feature of stroke is sudden onset. Symptoms appear within seconds to minutes, not gradually over days or weeks. Common warning signs include sudden weakness or numbness, especially on one side of the body, sudden confusion or difficulty speaking, sudden vision loss, sudden severe headache, and sudden loss of balance or coordination. Time is crucial in stroke treatment. For ischemic strokes, medications that dissolve clots can be given within a few hours of symptom onset, potentially reversing the damage. Procedures to physically remove clots can extend this window somewhat. But with each passing minute, more brain tissue dies. The medical community uses the phrase, "time is brain," to emphasize the urgency. For every minute a stroke goes untreated, an estimated 1.9 million neurons die. The faster treatment begins, the better the chance of good recovery. For hemorrhagic strokes, treatment focuses on controlling the bleeding, reducing pressure, and managing complications. Surgery may be needed to repair the damaged vessel or remove accumulated blood. The silent strokes. Not all strokes announce themselves with dramatic symptoms. Silent strokes are small strokes that cause permanent damage but produce no obvious symptoms at the time they occur. They are called silent not because they do no harm, but because the harm is subtle enough to go unnoticed. A person may not realize they've had a stroke at all. These small infarcts, areas of dead tissue, accumulate over time, particularly in individuals with cardiovascular risk factors like high blood pressure, diabetes, or high cholesterol. Each one damages a small region of the brain. Individually, the effects may be imperceptible. Collectively, they add up. Over years, the accumulation of silent strokes can lead to noticeable cognitive decline, problems with memory, slowed thinking, difficulty with complex tasks, and changes in mood or personality. Walking may become unsteady. Bladder control may be affected. The decline is gradual enough that it may be attributed to normal aging, but it represents real structural damage to the brain. Brain imaging studies have revealed that silent strokes are surprisingly common, especially in older adults. Estimates suggest that by age 70, about 1 in 4 people has evidence of at least one silent stroke on brain scans. The recognition of silent strokes has important implications. It means that brain health is not an all-or-nothing proposition. Small injuries can accumulate below the threshold of awareness, causing decline that might be prevented. The same strategies that reduce the risk of obvious strokes, controlling blood pressure, managing diabetes, avoiding smoking, staying physically active, eating a healthy diet, also reduce the risk of silent strokes. Every small stroke prevented is a small piece of cognitive health preserved. Every modification to risk factors is an investment in the brain's future. The brain ages, but much of what we attribute to inevitable decline may actually be preventable injury. Aneurysms. Time bombs in the brain. An aneurysm is a weak spot in a blood vessel wall that bulges outward like a balloon. In the brain, aneurysms typically form at branching points of arteries, where the constant pressure of blood flow stresses the vessel wall. Most brain aneurysms cause no symptoms and are discovered only incidentally during imaging done for other reasons. They may remain stable for years or even a lifetime, never growing or rupturing. But some grow larger over time, and larger aneurysms are at higher risk of rupture. When an aneurysm bursts, blood spills into the space surrounding the brain, causing a subarachnoid hemorrhage. The experience of aneurysm rupture is often described as the worst headache of one's life, sudden and explosive. It may be accompanied by nausea, vomiting, stiff neck, sensitivity to light, loss of consciousness, or seizures. This is a medical emergency requiring immediate treatment. Without intervention, the bleeding can be fatal or cause severe disability. Even with treatment, the outcomes vary widely. Some people recover well, others face permanent neurological deficits. Complications can include rebleeding if the aneurysm is not secured, vasospasm, where blood vessels constrict and reduce blood flow to the brain, and hydrocephalus, where blood blocks the normal circulation of cerebrospinal fluid. Treatment options include surgical clipping, where a neurosurgeon places a tiny metal clip across the neck of the aneurysm to seal it off, and endovascular coiling, where a catheter is threaded through blood vessels to the aneurysm, and tiny platinum coils are deposited inside it to promote clotting and seal it from within. Both approaches have risks and benefits, and the choice depends on the aneurysm's size, location, and shape, as well as the patient's overall health. For unruptured aneurysms discovered incidentally, the decision about whether to treat is complex, weighing the risk of rupture against the risks of treatment. Small aneurysms in low-risk locations may simply be monitored with periodic imaging. Infections of the brain. The brain is normally protected from infection by the blood-brain barrier, the skull, and the membranes surrounding the brain. But when these defenses are breached, infections can take hold with devastating consequences. Meningitis is an infection of the meninges, the membranes covering the brain and spinal cord. It can be caused by bacteria, viruses, or fungi. Bacterial meningitis is particularly dangerous, capable of causing severe brain damage or death within hours if not treated promptly. Symptoms include severe headache, fever, stiff neck, sensitivity to light, and altered mental status. Diagnosis is made by examining cerebrospinal fluid obtained through a lumbar puncture, commonly called a spinal tap. Encephalitis is inflammation of the brain tissue itself, most often caused by viral infections. Herpes simplex virus is a common culprit, but many viruses can cause encephalitis, including those transmitted by mosquitoes or ticks. Symptoms may include fever, headache, confusion, seizures, weakness, and changes in behavior or personality. The severity varies from mild cases that resolve on their own to life-threatening infections that cause permanent brain damage. Treatment depends on the cause. Bacterial infections require antibiotics. Herpes encephalitis responds to antiviral medications. Other forms may have no specific treatment beyond supportive care to manage symptoms and allow the immune system to clear the infection. Brain abscesses are collections of pus within the brain tissue, typically resulting from bacterial infections that spread from nearby structures like the sinuses or ears, or through the bloodstream from distant sites. They create localized swelling and pressure, and can cause headaches, fever, seizures, and neurological symptoms depending on their location. Treatment usually requires both antibiotics and surgical drainage of the abscess. Even with successful treatment of the infection, some patients are left with lasting neurological deficits or epilepsy. The brain's response to infection, the inflammation and swelling, can itself cause injury, even as it fights off the invading organisms. Tumors in the brain. When cells within the brain or its surrounding structures begin to grow abnormally, tumors form. These can be primary brain tumors, originating in the brain itself, or metastatic tumors, cancer that has spread from elsewhere in the body. Brain tumors vary enormously in their behavior. Some are benign, growing slowly and causing symptoms mainly through pressure on surrounding structures. Others are malignant, growing aggressively and infiltrating normal brain tissue. Even benign tumors can be life-threatening in the brain because the skull provides no room for expansion. As a tumor grows, it increases pressure within the skull, compressing normal brain tissue and potentially blocking the flow of cerebrospinal fluid. Symptoms depend on the tumor's size and location. Headaches, often worse in the morning, are common. Seizures may occur. Weakness, numbness, vision changes, difficulty speaking, personality changes, and cognitive decline can all result from tumors pressing on specific brain regions. Diagnosis typically involves brain imaging with CT or MRI scans, sometimes enhanced with contrast dye to highlight abnormal tissue. In some cases, a biopsy is needed to determine the tumor type and guide treatment. Treatment options include surgery to remove as much of the tumor as safely possible, radiation therapy to kill remaining cancer cells, and chemotherapy. For some benign tumors in accessible locations, complete surgical removal may be curative. Malignant brain tumors present greater challenges. Glioblastoma, the most aggressive primary brain tumor, infiltrates surrounding tissue extensively, making complete removal impossible. Even with aggressive treatment combining surgery, radiation, and chemotherapy, the prognosis is often measured in months to a few years. Research continues to search for new treatments, targeted therapies that attack specific molecules in tumor cells, immunotherapy that harnesses the patient's immune system to fight the cancer, and innovative surgical techniques to remove tumors that were once considered inoperable. Each advance offers hope, but brain cancer remains one of the most difficult challenges in medicine. Seizures after brain injury. Epileptic seizures are abnormal, excessive electrical discharges in the brain that can cause a wide range of symptoms, from brief lapses of awareness to violent convulsions. While epilepsy can develop for many reasons, brain injury is a significant cause. Trauma that scars the brain creates areas of abnormal tissue that can become seizure foci, spots from which seizures originate. Stroke, infection, tumors, and other brain injuries can all lead to epilepsy. Sometimes seizures begin immediately after the injury. Other times, they develop months or even years later, a phenomenon called late post-traumatic epilepsy. The experience of a seizure varies depending on which part of the brain is involved. Focal seizures, originating in one area, may cause unusual sensations, emotions, or movements in one part of the body. The person may remain conscious or have altered awareness. Generalized seizures involve both sides of the brain and cause loss of consciousness. Tonic-clonic seizures, formerly called grand mal seizures, are the most dramatic. The person loses consciousness, the body stiffens, then jerks rhythmically. Breathing may be irregular, and the person may bite their tongue or lose bladder control. After the seizure ends, there is often a period of confusion and fatigue called the postictal state. Witnessing a seizure can be frightening, but most seizures stop on their own within a few minutes. The priority is to keep the person safe. Move dangerous objects away, cushion the head, turn them on their side to keep the airway clear, and stay with them until they recover. Never try to hold them down or put anything in their mouth. Emergency medical help should be called if the seizure lasts more than 5 minutes, if another seizure begins before the person recovers, if the person is injured, or if it's their first seizure. For those diagnosed with epilepsy, anti-seizure medications can often control or reduce seizures, allowing people to live normal lives. When medications don't work, other options include surgery to remove the seizure focus, electrical stimulation devices, or special diets like the ketogenic diet. The invisible injuries, psychological trauma, brain injury, affects not just the physical structure of the brain, but also the mind and emotions. Depression, anxiety, post-traumatic stress disorder, and personality changes are common after brain injury, whether the injury is structural or not. The relationship is complex and bidirectional. The injury itself may damage brain regions involved in emotional regulation, like the frontal lobes or limbic system. The inflammatory and chemical changes that follow injury can affect neurotransmitter systems that regulate mood. But psychological factors matter too. The experience of being injured, the loss of abilities, changes in relationships and roles, uncertainty about the future, all take an emotional toll. Depression after brain injury is particularly common, affecting perhaps 30–50% of survivors. Symptoms include persistent sadness, loss of interest in activities, changes in sleep and appetite, fatigue, difficulty concentrating, feelings of worthlessness, and thoughts of death. Distinguishing between depression and the direct effects of brain injury can be challenging, since they share many symptoms. But recognizing and treating depression is crucial because it profoundly affects recovery and quality of life. Anxiety is also common, manifesting as excessive worry, restlessness, irritability, difficulty concentrating, and physical symptoms like rapid heartbeat or shortness of breath. Post-traumatic stress disorder can develop after the frightening experience of injury, especially in cases involving violence, accidents, or military combat. Intrusive memories, nightmares, avoidance of reminders, hypervigilance, and emotional numbness characterize PTSD. Personality changes are perhaps the most distressing consequence for families. The person who returns from brain injury may seem like a different individual, more impulsive, less patient, quick to anger, or emotionally blunted. These changes reflect damage to the frontal lobes, the brain's executive control center. Treatment for psychological consequences of brain injury is multimodal. Psychotherapy to address thoughts and behaviors, medications to manage symptoms, social support, and gradual reintegration into meaningful activities. Recovery of the mind and emotions often lags behind physical recovery, requiring patience and understanding from all involved. The gift of neuroplasticity. Despite all the ways brain injury can devastate, there is hope rooted in the brain's most remarkable property, neuroplasticity. This term refers to the brain's ability to change its structure and function in response to experience. Throughout life, the brain continuously modifies its connections, strengthening some, pruning others, even creating new neurons in certain limited regions. This capacity for change is what allows us to learn, to remember, to adapt, and it is what allows the injured brain to recover. After injury, the brain can reorganize itself, recruiting undamaged areas to take over functions that were lost. The process is neither quick nor automatic. It requires repetition, practice, and effort. When a stroke damages the motor cortex on one side of the brain, causing weakness in the opposite arm, intensive physical therapy can help the brain find new ways to control that arm. Nearby undamaged tissue may be recruited, or regions on the other side of the brain may contribute. The key is intensive, repetitive practice of the lost function. Each movement, however imperfect, sends signals through the nervous system. Over time, the brain learns new patterns, forges new connections. What seemed impossible becomes difficult. Difficult becomes manageable. Manageable becomes automatic again. Neuroplasticity also underlies cognitive recovery. When brain injury impairs memory, attention, or language, cognitive rehabilitation exercises the affected functions. Practicing memory strategies, doing attention training tasks, or working with a speech therapist on language all harness neuroplasticity. The brain is not fixed. Even in adulthood, even after injury, it can change, but change requires the right conditions. A brain that has emerged from the acute injury phase, freedom from complications like ongoing seizures, adequate stimulation and challenge, rest and sleep to consolidate new learning, and motivation and emotional support to persist through difficulty. Recovery is a marathon, not a sprint, and neuroplasticity is the reason that improvement can continue for months to years after injury. Rehabilitation, the long road home. After the acute crisis of brain injury passes, after the bleeding is controlled, the swelling reduced and medical stability achieved, the journey of rehabilitation begins. Rehabilitation is the process of relearning lost skills, adapting to remaining disabilities, and maximizing independence and quality of life. It is often the longest phase of recovery, stretching over months to years. A team of specialists typically guides this process. Physiatrists, doctors specializing in physical medicine and rehabilitation, coordinate care. Physical therapists work on strength, balance, and mobility. Occupational therapists help with daily living skills like dressing, bathing, and cooking. Speech therapists address not only speech but also swallowing and cognitive communication. Neuropsychologists assess cognitive functioning and provide cognitive rehabilitation for problems with memory, attention, and executive functions. Rehabilitation psychologists address emotional adjustment and coping strategies. Social workers help navigate the complex systems of insurance, benefits, and community resources. The intensity of therapy matters. Research has shown that more intensive therapy, more hours per day, leads to better outcomes. But intensive therapy is demanding, requiring motivation and effort from patients who may be exhausted, discouraged, and coping with pain or other symptoms. The goals of rehabilitation evolve over time. Early on, the focus may be on basic functions: swallowing safely, sitting up, standing, taking a few steps, communicating basic needs. Later, goals become more complex: walking independently, returning to work or school, driving, managing a household. Throughout the process, adaptation is key. If a function cannot be fully restored, assistive devices and strategies can compensate. Cannot walk? A wheelchair provides mobility. Cannot speak clearly? Communication devices offer alternatives. Cannot remember appointments? Systems and alarms compensate. The measure of success is not returning to exactly the way things were, but achieving the highest possible level of function and participation in life. The family's journey. Brain injury happens not just to an individual but to an entire family. When someone sustains a serious brain injury, their spouse, children, parents, and siblings are all thrust into a new reality they never anticipated. The person they knew may seem changed, their personality altered, their abilities diminished. The future they had envisioned together evaporates, replaced by uncertainty. Families face enormous challenges. navigating the medical system, making difficult decisions about treatment and care, managing financial strain, reorganizing household responsibilities, and coping with their own grief and stress while trying to support their injured loved one. The emotional journey is complex. Initially, there may be shock and denial, an inability to fully comprehend what has happened. As reality sets in, grief emerges. Grief not for someone who has died, but for the person who was, for the life that was planned. Anger may arise. Anger at the person or circumstances that caused the injury. Anger at the unfairness. Anger even at the injured person for changing. Guilt often follows. Guilt over feeling angry. Guilt over not being able to do more. Guilt over needing breaks or experiencing moments of joy. These emotions are normal, natural responses to an overwhelming situation. Family members often become caregivers, a role for which most are unprepared. Learning to manage medications, assist with physical care, monitor for complications, and provide emotional support is demanding. The caregiver's own needs for rest, social connection, and emotional processing may be neglected. Caregiver burnout is a real risk, manifesting as exhaustion, depression, social withdrawal, and physical health problems. Support for families is as crucial as support for patients. Respite care, counseling, support groups, and education about brain injury all help families adapt and sustain their caregiving over the long term. The truth is that recovery from brain injury is not an individual achievement, but a family undertaking, requiring resilience, flexibility, and compassion from everyone involved. Memory, fragile and precious. Among the many functions the brain performs, few are more central to our sense of self than memory. Our memories define us, connecting us to our past, orienting us in the present, and allowing us to imagine the future. Brain injury can disrupt memory in multiple ways. Retrograde amnesia refers to loss of memories from before the injury. Someone may forget the events leading up to an accident, or in more severe cases, lose years of memories. Anterograde amnesia is the inability to form new memories after the injury. The person may be unable to remember conversations from minutes ago, unable to learn new information, living in a perpetual present that slips away as quickly as it arrives. The hippocampus, a seahorse-shaped structure deep in the brain, is critical for forming new memories. Damage to both hippocampi, from stroke, trauma, or lack of oxygen, can cause profound anterograde amnesia. The famous patient known as HM, who had his hippocampi removed to treat severe epilepsy, could not form new memories for the rest of his life. He could remember his childhood and early adulthood, but every person he met after surgery was a stranger each time he encountered them. Every conversation was new. Every meal was a surprise. His case taught neuroscientists fundamental lessons about how memory works, but at the cost of his own ability to live a remembered life. Not all memory problems after brain injury are so severe. More commonly, people experience difficulties with short-term memory, struggling to remember appointments, conversations, or where they placed objects. Working memory, the ability to hold information in mind while manipulating it, may be impaired, making it hard to follow complex instructions or do mental math. Prospective memory, remembering to do things in the future, is often affected, leading to missed appointments or forgotten tasks. These problems are frustrating and affect every aspect of daily life. Compensatory strategies can help, using calendars, alarms, and reminders, establishing routines, writing things down immediately, and using external memory aids. While these strategies cannot restore memory to what it was, they can make it possible to function effectively despite memory impairments. Attention, the gateway to cognition. Before we can remember something, learn something, or think about something, we must first pay attention to it. Attention is the cognitive function that allows us to focus on relevant information while filtering out distractions. It seems simple, automatic even, until it's disrupted. Brain injury commonly affects attention in various ways. Sustained attention, the ability to maintain focus over time, may be impaired, making it difficult to complete tasks or follow conversations. Selective attention, focusing on one thing while ignoring others, may be compromised, leading to distractibility. Divided attention, multitasking, often becomes impossible after brain injury. The world becomes overwhelming when attention is impaired. A conversation in a quiet room may be manageable, but add background noise and it becomes impossible to follow. Reading a paragraph may work, but reading a page overwhelms. Watching a movie, cooking a meal, or participating in a meeting may require levels of sustained and divided attention that are no longer available. The person may seem inattentive, unmotivated, or oppositional, when in reality their brain simply cannot maintain focus. This mismatch between what is expected and what is possible creates frustration for everyone involved. Treatment for attention problems typically involves a combination of strategies. Cognitive rehabilitation may include attention training exercises, though their effectiveness is debated. Environmental modifications help, reducing distractions, breaking tasks into smaller steps, taking frequent breaks, using timers to structure work periods. Stimulant medications, similar to those used for ADHD, sometimes help improve attention after brain injury. Understanding and accommodating attention limitations is crucial. Rather than pushing through fatigue and distraction, which tends to worsen performance and increase frustration, working within current limitations while gradually increasing demands allows for sustainable progress. Executive functions, the brain's CEO. The frontal lobes, particularly the prefrontal cortex, house what neuroscientists call executive functions, the high-level cognitive abilities that allow us to plan, organize, solve problems, monitor our own behavior, and regulate emotions. These functions are the brain's chief executive officer, managing and coordinating all other cognitive processes. When executive functions are impaired by brain injury, the effects ripple through every aspect of life. Planning becomes difficult. The person may know what needs to be done, but cannot organize the steps to accomplish it. Starting tasks is hard. Stopping tasks is hard. Shifting from one task to another is hard. Impulsivity increases as the ability to pause and consider consequences before acting diminishes. Someone might make inappropriate comments, spend money recklessly, or take unsafe risks. Flexibility of thought decreases, making it hard to adapt when plans change or to consider alternative perspectives. Self-monitoring suffers. The person may not realize when they're making mistakes or when their behavior is inappropriate. Emotional regulation becomes difficult, leading to mood swings, angry outbursts, or emotional lability, where tears or laughter come unexpectedly and excessively. These changes are among the most challenging consequences of brain injury because they affect personality and social relationships. The person with executive dysfunction may intellectually understand what they should do, but cannot consistently implement that understanding. They may set goals but never accomplish them, not from lack of desire but from inability to plan and execute. They may recognize that they've hurt someone's feelings but do it again in the next interaction because self-monitoring is impaired. Families often describe this as the person being not themselves anymore. Treatment focuses on external structure and support. Establishing routines reduces the need for planning and decision-making. Breaking complex tasks into simple steps with prompts at each stage compensates for planning difficulties. Teaching specific problem-solving strategies provides a framework to apply when challenges arise. But recovery of executive functions is often incomplete, and long-term support may be needed. Language. When words fail. Language is a uniquely human capacity, the ability to use symbols to communicate complex thoughts and ideas. It depends on specialized regions in the brain, typically in the left hemisphere. When these regions are damaged by stroke, trauma, or other injury, language can be disrupted in various ways. A family of disorders called aphasia. Broca's aphasia results from damage to the frontal lobe. Speech is effortful and halting. Words come out slowly, one at a time, often missing small grammatical words. Understanding language is relatively preserved, so the person knows what they want to say, but cannot get the words out. The frustration is immense. Wernicke's aphasia results from damage to a region in the temporal lobe. Speech is fluent, even excessive, but it makes little sense. Words may be substituted or invented, creating what sounds like gibberish. The person often doesn't realize their speech is incomprehensible. Understanding language is severely impaired. They may not comprehend questions or instructions, adding to the confusion. Global aphasia, resulting from more extensive damage, impairs both expression and comprehension severely. The person may be able to produce only a few words or sounds and understand very little. Other types of aphasia affect reading, writing, repeating words, or naming objects. Living with aphasia is profoundly isolating. Imagine having thoughts, opinions, needs, and feelings, but being unable to express them. Imagine hearing people talk, but not understanding the words. Social relationships suffer. Work becomes impossible for jobs requiring language. Even basic activities like ordering food or using the phone become challenges. Speech therapy is the primary treatment for aphasia. Therapists work on strengthening remaining language abilities, teaching compensatory strategies, and training communication partners to modify their communication to be more accessible. Alternative communication methods, like gestures, drawing, or communication boards, may be introduced. Recovery is variable. Some people regain most language function, especially with early intensive therapy. Others retain significant deficits. But even partial recovery of language can dramatically improve quality of life and social connection. The visual system, more than meets the eye vision, depends not only on the eyes, but on extensive brain processing. The optic nerves carry visual information from the eyes to the back of the brain, where the visual cortex resides. Additional brain regions process different aspects of vision, color, motion, faces, spatial relationships. Brain injury can disrupt vision at multiple points along this pathway. Damage to the optic nerves, or visual cortex, can cause blindness in part of the visual field. Hemianopia, loss of half the visual field, is common after stroke. The person may be unaware of anything on one side, not seeing food on that side of the plate, bumping into door frames, or not noticing people approaching from that direction. More subtle visual problems are also common. Visual processing speed may be slowed, making it hard to take in information quickly. Visual attention may be impaired, causing the person to miss important details or have difficulty finding objects. Visual perception may be disturbed, making it hard to judge distances, recognize faces, or interpret complex visual scenes. Double vision may occur if the cranial nerves controlling eye movements are damaged. Visual neglect, where the person ignores one side of space despite intact vision, can occur with right hemisphere damage. They may dress only one side of their body, eat from only one side of the plate, or draw a clock with all the numbers on one side. Adaptations and therapy can help with visual problems. For visual field loss, scanning training teaches the person to turn their head to compensate for the missing field. Prism glasses may shift the image to expand the usable field. For visual processing problems, reducing clutter, increasing contrast, and allowing extra time help. For neglect, cueing the person to attend to the neglected side gradually improves awareness. For double vision, covering one eye or using special lenses may help until the condition resolves. Vision is such an important sense that even partial recovery or successful adaptation can significantly improve independence and quality of life. Movement. From paralysis to coordination, the brain controls every movement we make, from the gross motor actions of walking to the fine motor control of writing. Different brain regions contribute to movement in distinct ways. The motor cortex in the frontal lobe sends commands to muscles. The basal ganglia deep in the brain modulate movement, making it smooth and coordinated. The cerebellum at the back of the brain fine-tunes movements, maintains balance, and coordinates complex sequences. Damage to any of these regions disrupts movement in characteristic ways. Stroke or trauma to the motor cortex causes weakness or paralysis on the opposite side of the body, a condition called hemiparesis or hemiplegia. The weakness is typically more severe in the arm than the leg. Initially, the affected limbs may be completely flaccid, hanging limply. As time passes, spasticity often develops, where muscles become tight and stiff, resisting stretching. The arm may curl toward the body, the hand clench into a fist, the leg become rigid. Spasticity can be painful and interferes with movement and care. Damage to the basal ganglia, as can occur with certain types of stroke or traumatic brain injury, may cause movement disorders like tremor, where parts of the body shake rhythmically, or dystonia, where muscles contract involuntarily, creating abnormal postures. Cerebellar damage causes ataxia, incoordination of movement. Actions become clumsy and imprecise. The person may overshoot when reaching for objects, have difficulty with tasks requiring fine motor control, walk with a wide-based unsteady gait, and have difficulty with rapid alternating movements. Speech may become slurred and scanning. Physical therapy is essential for recovering movement after brain injury. Therapists use various approaches: repetitive task practice to retrain movement patterns, strength training, stretching to manage spasticity, balance exercises, and gait training. Occupational therapists focus on using the affected limbs for functional activities. Medications can reduce spasticity. Botulinum, toxin, injections temporarily weaken spastic muscles. Assistive devices like braces, canes, or walkers improve safety and independence. Even when full recovery is not possible, adaptations allow for meaningful improvement in mobility and function. Swallowing, an underappreciated skill. Swallowing seems automatic, something we do thousands of times a day without thought. But it is actually a complex process, requiring precise coordination of muscles in the mouth, throat, and esophagus, all controlled by the brainstem and coordinated with breathing. Brain injury can disrupt this coordination, causing dysphagia, difficulty swallowing. The consequences can be serious. If food or liquid goes down the airway instead of the esophagus, it can cause choking or aspiration pneumonia, a lung infection that develops when foreign material enters the lungs. Some people aspirate silently, without coughing, making the problem difficult to detect. Signs of dysphagia include coughing or choking while eating or drinking, a wet or gurgly voice after swallowing, food remaining in the mouth after swallowing, difficulty chewing, drooling, weight loss, or recurrent pneumonia. Speech-language pathologists assess swallowing through clinical evaluation and sometimes instrumental studies like video fluoroscopy, which uses X-ray to watch what happens when the person swallows. Treatment depends on the nature of the problem. Diet modifications may be needed, thickening liquids to slow their flow, pureeing foods to reduce the need for chewing, avoiding mixed textures that are hard to manage. Postural changes can help. Tucking the chin directs food away from the airway. Turning the head closes off one side of the throat to direct food down the other. Swallowing exercises strengthen and coordinate the muscles. In severe cases, temporary or permanent feeding tubes may be necessary to provide nutrition safely while bypassing the swallowing mechanism. Many people recover swallowing function with therapy, progressing from tube feeding to modified diets to normal eating. But recovery can be slow, and patience is essential. The simple pleasure of eating with others, tasting favorite foods, sharing meals, is something we take for granted until it's compromised. Sleep after brain injury. Sleep is essential for brain health, and brain injury profoundly affects sleep. Many people with brain injury experience sleep disturbances, difficulty falling asleep, frequent nighttime awakenings, early morning awakening, or excessive daytime sleepiness. These problems may result from damage to brain regions that regulate sleep-wake cycles, from medications used to treat other symptoms, from pain or discomfort, from mood disorders like depression or anxiety, or from specific sleep disorders. Sleep apnea, where breathing repeatedly stops during sleep, is more common after brain injury, especially if there is damage to the brainstem regions that control breathing. Circadian rhythm disorders may occur, where the internal body clock that normally synchronizes sleep with day-night cycles is disrupted. The person may be awake all night and sleep all day, or have an irregular sleep pattern with no consistent schedule. Nightmares and night terrors are common, especially when PTSD accompanies the brain injury. The sleep disturbances worsen other symptoms. Poor sleep impairs cognitive function, mood, pain tolerance, and physical recovery. It increases fatigue and irritability. It interferes with learning and consolidation of memories formed during rehabilitation. Addressing sleep problems is crucial for overall recovery. Sleep hygiene measures help. Maintaining a consistent sleep schedule, creating a comfortable sleep environment, avoiding caffeine and screens before bed, getting regular exercise but not too close to bedtime, and establishing a calming bedtime routine. Treatment of underlying conditions like sleep apnea, depression, or pain improves sleep. Medications for sleep may be used carefully, as some can worsen cognitive problems. Cognitive behavioral therapy for insomnia teaches techniques to improve sleep without medication. The goal is restorative sleep that allows the brain to heal and consolidate the gains made during waking hours. Pain, the brain's alarm system. Pain is meant to be protective, an alarm system alerting us to injury and prompting protective responses. But after brain injury, pain often becomes chronic, persisting long after any initial tissue damage has healed. Headaches are the most common pain complaint, occurring in up to 90% of people after traumatic brain injury. Post-traumatic headaches can resemble tension headaches, migraines, or have mixed features. They may be triggered by physical exertion, stress, lack of sleep, or appear without obvious cause. Some are daily and unrelenting. Others come in episodic attacks. The mechanisms are not fully understood, but involve altered pain processing in the brain. Neuropathic pain, pain caused by damage to the nervous system itself, can occur when brain injury damages pain pathways. This type of pain is often described as burning, shooting, stabbing, or electric shock-like. It may occur in areas that have no tissue damage, arising from abnormal signaling in the nervous system. Central pain syndrome, a specific type of neuropathic pain, can develop after stroke or other brain injury, causing constant burning pain, often in areas of the body affected by sensory loss. Musculoskeletal pain is also common, resulting from altered movement patterns, muscle tension, or spasticity. Managing chronic pain after brain injury is challenging. Medications have limitations. Many pain medications can worsen cognitive problems or cause sedation. Opioids, while effective for acute pain, carry risks of dependence and are often less effective for chronic pain. A multimodal approach is usually needed. Physical therapy to address musculoskeletal issues, medications chosen carefully to balance, pain relief with side effects, cognitive behavioral therapy to change thoughts and behaviors related to pain, relaxation techniques like deep breathing or progressive muscle relaxation, and when appropriate, procedures like nerve blocks or neuromodulation. Living with chronic pain is exhausting and demoralizing. It compounds the other challenges of brain injury. Acknowledging the pain, treating it seriously, and working persistently to manage it improves overall function and quality of life. The developing brain and injury children's brains are not simply smaller versions of adult brains. They are developing organs, still forming connections, still maturing. This creates both vulnerabilities and advantages when injury occurs. On one hand, the developing brain may be more vulnerable to certain insults. Shaking an infant can cause severe brain injury because the brain is softer and the neck muscles weak. Even mild impacts during development may disrupt ongoing processes of neuronal migration and connection formation. On the other hand, the young brain's plasticity, its capacity to reorganize, is greater than in adults. This can allow for remarkable recovery. Young children who sustain brain injuries may initially seem to recover well, only to develop problems years later as they fail to acquire skills that were not yet expected at the time of injury. A toddler with frontal lobe injury may seem fine, but when they reach school age, executive function problems become apparent. This phenomenon, called growing into deficits, makes it difficult to predict long-term outcomes after early brain injury. Adolescents face unique challenges. Their brains are still maturing, particularly the frontal lobes, which continue developing into the mid-20s. They are also in a life stage characterized by risk-taking, peer influence, and emerging independence. Brain injury during adolescence can derail normal development, affecting education, social relationships, and the transition to adulthood. Academic accommodations may be needed. Special education services can provide support. Family education is crucial, so parents understand the invisible disabilities their child faces. Helping children and adolescents understand their own injury and its effects empowers them to advocate for their needs. Peer support, connecting with other young people who have experienced brain injury, reduces isolation. With appropriate support, many children and adolescents with brain injury go on to lead fulfilling lives, their resilience and the brain's plasticity combining to allow adaptation and growth. The aging brain and injury. At the other end of the lifespan, elderly individuals face their own challenges with brain injury. The aging brain has less reserve, less plasticity, and often coexists with other medical conditions. Falls are the leading cause of traumatic brain injury in older adults, and even minor head impacts can cause serious injury, especially in those taking blood-thinning medications. Subdural hematomas may accumulate slowly, causing gradual changes in cognition or behavior that could easily be attributed to dementia or depression. Stroke risk increases dramatically with age, and recovery from stroke tends to be slower and less complete in older adults. Older adults may have less stamina for intensive rehabilitation. They may have hearing or vision impairments that complicate therapy. Cognitive impairment that existed before the injury makes recovery more difficult. Social isolation is more common, and many elderly individuals lack the family support networks that younger people may have. Yet dismissing elderly individuals as too old for rehabilitation is both inaccurate and unjust. Many older adults achieve meaningful recovery with appropriate treatment. The goals may differ: returning to independent living, managing medications safely, avoiding falls, maintaining social connections. These are worthy goals that dramatically affect quality of life. Adaptations in the home environment become especially important: removing tripping hazards, improving lighting, installing grab bars, using assistive devices. In-home services may allow someone to remain at home rather than move to a facility. Adult day programs provide stimulation and respite for caregivers. The key is individualized care that respects the person's autonomy and goals while providing appropriate support. Brain injury in older adults is not inevitably catastrophic, but it requires thoughtful, comprehensive care that addresses the whole person within the context of their age, health, and life circumstances. Preventing brain injury. While we have focused on understanding and treating brain injury, prevention is perhaps the most powerful intervention. Many brain injuries are preventable. Motor vehicle accidents are a leading cause, and simple measures save lives. Wearing seat belts, using appropriate car seats for children, not driving impaired by alcohol or drugs, not driving distracted, obeying speed limits. Helmets reduce brain injury in motorcyclists, bicyclists, skiers, and participants in contact sports. They should be properly fitted and replaced after any impact. For children, safety equipment designed for their size and developmental stage is essential. Falls are highly preventable, especially in older adults and young children. Home modifications, balance training, medication review to reduce fall risk, and prompt treatment of vision and vestibular problems all help. Preventing violence, including intimate partner violence, child abuse, and assault, prevents the traumatic brain injuries that result. Public health approaches address social determinants: poverty, substance use, access to mental health care, conflict resolution skills. For stroke prevention, controlling cardiovascular risk factors makes an enormous difference. Treating high blood pressure, managing diabetes, lowering cholesterol, stopping smoking, maintaining a healthy weight, exercising regularly, eating a healthy diet. These measures sound simple, but their impact is profound. Every brain injury prevented spares an individual and their family from potential devastation. Every small change in behavior, policy, or environment that reduces risk is worthwhile. Prevention requires action at multiple levels: individual choices, family practices, community design, public policy, and cultural norms around safety. The return on investment is immeasurable. Lives saved, disabilities avoided, suffering prevented. The brain is precious and irreplaceable. Protecting it is one of the most important things we can do for ourselves and for future generations. Research, the frontier of hope. Despite centuries of studying the brain and decades of research on brain injury, much remains unknown. Why do some people recover well from seemingly severe injuries, while others remain profoundly disabled from apparently minor ones? Can we predict who will develop chronic problems? Can interventions in the acute phase alter the long-term trajectory? Are there medications, stem cells, or other treatments that can promote repair of damaged neurons? Current research explores these questions using increasingly sophisticated tools. Advanced imaging techniques reveal subtle changes invisible on standard scans. Biomarkers, measurable substances in blood or cerebrospinal fluid, may predict outcomes or track recovery. Researchers are investigating neuroprotective agents, medications given immediately after injury to protect neurons from secondary damage. While none have proven effective in large clinical trials yet, each trial teaches us more about the mechanisms of injury. Stem cell therapy holds promise. Laboratory studies show that stem cells can differentiate into neurons and support healing. Early human trials are underway, though challenges remain in determining the best type of stem cells, timing of delivery, and methods of administration. Neuromodulation, using electrical or magnetic stimulation of the brain, may enhance recovery, especially when combined with rehabilitation. Efforts to understand and treat chronic traumatic encephalopathy continue, searching for ways to diagnose it in living patients and to prevent or slow its progression. Each research advance brings us closer to better treatments, but progress is slow, and those living with brain injury now cannot wait for future discoveries. They need support, services, and compassion today. Research offers hope for the future, but must be matched with investment in services for the present. Both are necessary. Both are urgent. The brain's complexity means that unlocking its mysteries will take time, but every answer leads to new questions, and every question pursued is another step toward better outcomes for those affected by brain injury. Technology and innovation. Technology is transforming brain injury care in remarkable ways. Advanced imaging, like functional MRI, can reveal brain activity in people who appear unresponsive, detecting consciousness where none was apparent. Brain-computer interfaces are being developed that allow people with paralysis to control computers, prosthetic limbs, or communication devices using only their thoughts. Sensors implanted in the motor cortex detect the intention to move and translate it into commands. Individuals with locked-in syndrome or severe paralysis can type messages, browse the internet, or control their environment. Virtual reality is being used in rehabilitation, creating immersive environments where patients can practice real-world skills safely. A person relearning to walk can practice navigating obstacles in virtual settings. Someone with social cognitive deficits can practice interactions with virtual characters. The technology provides repetition, graduated difficulty, and immediate feedback. Wearable sensors can monitor activity, detect falls, or track therapy compliance, providing data to guide treatment. Smartphone apps offer cognitive training, medication reminders, and symptom tracking. Telemedicine allows specialist consultation for patients in rural areas or those unable to travel. Robotics assist with rehabilitation, providing intensive, repetitive practice that would be impossible for human therapists to deliver. A robotic exoskeleton can support a person's weak leg while they practice walking, gradually reducing support as strength returns. These technologies are not replacing human care, but augmenting it, allowing clinicians to work more efficiently and patients to practice more intensively. As costs decrease and technology improves, these innovations will become more accessible. The future of brain injury treatment will blend human expertise and compassion with technological capabilities, offering possibilities that previous generations could not have imagined. Quality of life, redefining success. Medical science focuses on survival and function. Can the person live? Can they walk, talk, think? But those who have lived with brain injury emphasize something else: quality of life. What makes life meaningful and worthwhile? The answer varies for each person. For some, it's independence in daily activities. For others, it's maintaining relationships. For some, it's continuing to work or contribute. For others, it's engaging in hobbies or creative pursuits. Quality of life is subjective, deeply personal, and cannot be reduced to scores on functional assessments. Someone with severe physical disabilities may rate their quality of life as high if they have strong relationships, purpose, and adaptation. Someone with minimal physical impairment may rate theirs as low if they have lost meaningful activities or relationships. This reality challenges medical providers to broaden their definition of success. Is return to work the only valid goal? What about return to volunteering or to being present for family? Is independence in all activities necessary, or can interdependence and accepting help be acceptable? Who defines what a good outcome is? These are not just philosophical questions, but practical ones that shape rehabilitation goals and resource allocation. Person-centered care puts the individual's values and goals at the center. It asks not, "What can we fix?" but "What matters to you?" It recognizes that living with brain injury is not simply about recovering function, but about building a meaningful life within new limitations. Peer support plays a crucial role. Connecting with others who have walked similar paths provides hope, practical advice, and understanding that professionals, no matter how knowledgeable, cannot fully offer. Seeing someone farther along in their recovery, living well despite ongoing challenges, makes recovery seem possible. Hearing how others have adapted, what strategies work, what resources exist, provides practical guidance. Knowing that the struggles, frustrations, and grief are shared reduces isolation. Quality of life after brain injury is possible. It may look different than before. It may require adaptation, support, and time, but it is possible. And perhaps that is the most important message of all: the slow miracle of recovery. Recovery from brain injury is rarely dramatic. There is usually no single moment when everything suddenly improves. Instead, recovery is a slow accumulation of small gains. One day, the person can sit up for 5 minutes longer. Next week, they take 3 more steps. A month later, they remember the therapist's name. Progress is measured not in leaps, but in inches. For those involved, the slowness can be maddening. Each tiny gain is hard-won through effort and repetition. Setbacks occur. A complication, a plateau, a discouraging day when nothing seems to work. But gradually, imperceptibly, the small gains accumulate. Looking back over months, the change becomes apparent. The person who could not sit now walks with a walker. The person who could not speak now holds conversations. The person who could not remember now manages daily routines with support. This is the slow miracle of recovery. Not dramatic, but no less profound. It happens through the combination of neuroplasticity and effort, of professional expertise and personal determination, of family support and community resources. It happens day by day, repetition by repetition, hour by hour, in therapy, at home, in the community. There are no guarantees. Not everyone recovers fully. Some changes are permanent. But within those constraints, improvement is often possible. The brain adapts. The person adapts. New skills are learned. New strategies developed. New meanings found. Recovery is not about returning to exactly the way things were. It is about moving forward into a new way of being, carrying both the losses and the gains, the grief and the gratitude. Living with the long perspective. At some point in the journey, often years after the injury, the focus shifts from recovering to living with. The intense rehabilitation phase has ended. Progress has plateaued. The person and their family settle into a new normal. This transition can be difficult. The hope that sustained them through acute care and rehabilitation, the belief that full recovery was possible, must be adjusted to reflect reality. Grief resurfaces as the permanence of changes becomes clear. Yet this phase also brings its own gifts. As the frantic effort to recover eases, space opens for acceptance. The person begins to redefine themselves, not as a brain injury victim or survivor in constant battle, but as a whole person with strengths and limitations, interests and relationships, a history and a future. Acceptance does not mean giving up. It means acknowledging reality without being consumed by what was lost. It means finding ways to engage in meaningful activities despite limitations. It means building a life that is different but still worthwhile. Many people with brain injury describe a complex emotional landscape. Sadness for what was lost coexists with gratitude for what remains. Frustration with limitations coexists with pride in what has been accomplished. Grief for the past coexists with hope for the future. These contradictions do not need to be resolved. They can simply be held. Life after brain injury is not an either-or proposition, either recovered or not recovered, either disabled or not disabled. It is a both-and reality, both changed and still oneself, both limited and still capable, both grieving and still living. The unseen disabilities. One of the most challenging aspects of brain injury is that many of the most significant disabilities are invisible. Someone may look fine, walk normally, speak clearly, yet struggle profoundly with memory, attention, fatigue, or emotional regulation. These invisible disabilities create misunderstandings. Family members may think the person is being lazy or oppositional when they cannot complete tasks. Employers may not understand why someone cannot return to their previous job. Friends may drift away, not comprehending why the person seems different or cannot engage in activities they once enjoyed. The person themselves may look in the mirror and see someone who looks normal, creating cognitive dissonance with their experienced reality. Educating others about invisible disabilities is crucial but exhausting. Having to constantly explain why you cannot do things that look simple, why you need accommodations, why you are not the same despite looking fine, takes emotional energy. Some people with brain injury describe feeling like they are constantly defending themselves, justifying their limitations, proving they are not faking or exaggerating. Others stop trying to explain and simply withdraw, accepting isolation as easier than constant explanation. Society tends to understand and accommodate visible disabilities better than invisible ones. Wheelchair ramps, sign language interpreters, and large print materials all recognize and respond to visible needs. But quiet rooms for someone with sensory sensitivities, flexible schedules for someone with fatigue, or patience for someone with slowed processing speed are less automatic. Advocacy matters, both individual and collective. Disability rights movements have expanded society's understanding of disability beyond the visible and physical. Recognizing cognitive, emotional, and sensory disabilities as real and deserving of accommodation is a work in progress. Everyone affected by brain injury, whether patients, families, or professionals, has a role in this advocacy. Every time someone explains their needs, every time an accommodation is implemented, every time understanding replaces judgment, progress is made toward a society that recognizes and supports all forms of disability. The healthcare system, navigating complexity brain injury care, involves navigating one of the most complex systems imaginable: healthcare in the modern world. The journey begins in emergency departments, proceeds through intensive care units, acute rehabilitation hospitals, outpatient clinics, community services, and often cycles through these repeatedly. Each transition brings new providers, new systems, new authorizations needed. Coordinating care across multiple specialists, neurologists, physiatrists, neuropsychologists, therapists of various types, primary care doctors, is challenging. Each sees one piece of the puzzle. Someone must integrate the pieces into a coherent whole. Often that burden falls on patients and families who are least equipped to bear it, overwhelmed and exhausted themselves. Insurance becomes a constant battle. Prior authorizations, coverage denials, limits on therapy visits, battles over medical equipment or medications, all consume energy that could better be directed toward recovery. The rules seem arbitrary and contradictory. Therapy is approved until the person stops making measurable progress, yet often continued. Therapy is needed to maintain gains, even when new gains are not expected. Navigating disability benefits, whether through Social Security, private insurance, or veterans benefits, requires persistence and often professional assistance. The paperwork is overwhelming. The wait times are long, denials are common, and appeals necessary. Healthcare costs can be catastrophic even with insurance. Deductibles, copays, and uncovered services add up. Someone may need modifications to their home, specialized equipment, or attendant care that insurance does not cover. Lost income from inability to work compounds the financial strain. Medical bankruptcy is not uncommon after serious brain injury. Yet, through this maze, families persist. They learn to advocate, to appeal denials, to connect with social workers and case managers who can help. Support organizations provide guidance on navigating systems. Peer mentors who have walked the path before offer practical advice. The system is broken in many ways, but within it, people find ways to obtain the care they need. The question is why it must be so difficult, and what might be done to make essential care more accessible to all who need it. Hope and uncertainty. Throughout the journey with brain injury, two companions remain constant: hope and uncertainty. Hope that recovery will continue, that life will improve, that meaning can be found. Uncertainty about what the future holds, how much recovery is possible, what abilities will return. In the acute phase, uncertainty dominates. Will the person survive? Will they wake from coma? How severe will disabilities be? Gradually, as the picture clarifies, some uncertainties resolve, while others emerge. The person survived, but will they walk again? They're walking, but will they return to work? They're working, but will chronic problems develop later? Hope evolves too. Early hope may be for complete recovery, for a return to exactly the way things were. As time passes and limitations become clearer, hope must be recalibrated. It becomes hope for the best possible outcome within realistic constraints. Hope for adaptation, for finding new sources of meaning, for building a good life different from the one planned. This evolution of hope is not defeat, but maturity, a deepening understanding of what is possible and what matters most. Some describe going through cycles where hope and despair alternate. A setback brings despair. A small gain restores hope. An anniversary of the injury brings grief. A milestone achieved brings joy. These cycles are normal, part of the long adjustment to altered life. Healthcare providers walk a fine line between offering hope and being realistic. False hope that sets unrealistic expectations can lead to devastating disappointment. But excessive pessimism may become self-fulfilling if it leads to inadequate treatment or effort. The truth is that outcomes are difficult to predict. Two people with seemingly identical injuries may have vastly different trajectories. Prognostic uncertainty is real. This means that maintaining hope is rational, even in challenging circumstances, as long as hope is held gently, adjusted as reality unfolds. Hope is not denial. It is the belief that positive change remains possible, that suffering can find meaning, that the future, though uncertain, may hold good things yet unimagined. Spirituality and meaning-making brain injury often prompts profound questions about meaning, purpose, and the nature of existence. Why did this happen? What does it mean? How can suffering be understood? For many, spirituality or religious faith provides a framework for grappling with these questions. Belief in a higher power, an afterlife, or a greater purpose can offer comfort. Prayer, meditation, or religious community can provide support. Some find their faith strengthened by adversity, drawing closer to their spiritual practices. Others experience crisis of faith, struggling to reconcile a loving God with suffering. Still others, whether religious or not, engage in meaning-making through philosophy, creative expression, or connection with nature. Viktor Frankl, a psychiatrist who survived the Holocaust, wrote about finding meaning even in suffering. His approach, called logotherapy, suggests that humans can bear almost any hardship if they can find meaning in it. After brain injury, meaning might be found in various ways: in small moments of connection with loved ones, in progress achieved through hard work, in helping others who face similar challenges, in appreciating life's fragility and preciousness, in spiritual growth, in discovering inner strength. Meaning is not given but created, actively constructed by individuals as they make sense of their experiences. Not everyone needs explicit meaning-making. Some simply live day to day, doing what needs to be done, finding satisfaction in ordinary activities and relationships. There is no single right way to cope with brain injury. What matters is that individuals and families find approaches that resonate with their values and provide support. Chaplains, spiritual directors, therapists with training in existential issues, or peer mentors can facilitate this process for those who seek it. The questions raised by brain injury about identity, mortality, what makes life worthwhile, are ultimately questions every human faces. Brain injury simply brings them into sharp, unavoidable focus. Caregiving, the hidden patients. Behind every person with brain injury stands at least one caregiver, often many. These individuals, typically family members, provide daily assistance, emotional support, and advocacy. The demands of caregiving after brain injury are immense and extend far beyond practical tasks. Yes, caregivers may help with dressing, bathing, meals, medications, and appointments, but they also provide cognitive support, compensating for memory and planning deficits. They offer emotional support, managing their loved ones' frustration, grief, and anxiety, while managing their own. They serve as interpreters and advocates in medical settings. They reorganize their entire lives around caregiving, often sacrificing careers, social connections, and personal interests. The toll on caregivers is well documented. Depression, anxiety, physical health problems, social isolation, and financial strain are common. The term caregiver burden describes this accumulated stress. Yet many caregivers resist this language, seeing their role not as burden, but as love, duty, or choice. Both truths coexist. Caregiving can be profoundly meaningful and profoundly exhausting. Caregivers need support, but often do not seek it, focused on their loved one's needs rather than their own. They may feel guilty for needing help, for feeling tired or resentful, for wanting time for themselves. Support groups for caregivers provide a place to share experiences without judgment. Respite care, whether through in-home services or temporary residential programs, gives caregivers necessary breaks. Education about brain injury helps caregivers understand behaviors they might otherwise misinterpret. Learning that irritability or memory problems result from brain injury rather than personal choice reduces conflict and frustration. Counseling can address the complex emotions caregivers experience. Self-care is not selfish, but necessary. The analogy of putting on your own oxygen mask before helping others applies perfectly. Caregivers who maintain their own health and well-being are better able to provide sustained, compassionate care. Society owes an enormous debt to family caregivers, whose unpaid labor makes it possible for many people with brain injury to live at home rather than in institutions. Recognizing, supporting, and valuing caregivers is both a moral imperative and a practical necessity. Community reintegration. Eventually, the focus shifts from medical treatment and rehabilitation to reintegrating into community life. This means returning to or finding new roles in work, school, social activities, and community participation. The challenges are significant. Workplaces may not accommodate cognitive limitations. Schools may not provide adequate support. Social groups may not understand why the person seems different. Public spaces may be overwhelming for someone with sensory sensitivities or fatigue. Transportation can be an insurmountable barrier if driving is no longer possible and public transit inadequate. Housing may need to be adapted or changed if mobility is impaired. Vocational rehabilitation helps people return to work or find new employment suited to current abilities. Job coaches, workplace accommodations, retraining programs, and supported employment all facilitate this process. But employment rates after moderate to severe brain injury remain low, reflecting both genuine limitations and societal barriers. Educational supports through individualized education programs, IEPs, or 504 plans, help students remain in or return to school. But teachers may lack training in brain injury, and peers may not understand the invisible disabilities their classmate faces. Social reintegration is perhaps most challenging. Relationships may change or end. Making new friends is difficult when social skills are affected, energy is limited, and activities once enjoyed are no longer accessible. Community-based programs, designed for people with brain injury, provide socialization, activities, and support in understanding environments. These may include day programs, clubhouses, recreational programs, or support groups. While valuable, they also represent a form of segregation, a separate world for people with disabilities, rather than full inclusion in mainstream community life. The ideal is inclusive communities where people with brain injury participate fully in regular work, school, and social activities with whatever supports they need. We have not achieved this ideal. But every successful return to work, every student supported in a regular classroom, every person with brain injury participating in community activities moves us closer. Inclusion benefits everyone, enriching communities with diverse perspectives and challenging limiting assumptions about disability. Identity after brain injury. Who am I now? This question haunts many people after brain injury. The injury has changed them. Abilities they relied on may be diminished. Personality traits may have shifted. Roles they filled may no longer be possible. The person looks in the mirror and sees their own face, but feels like a stranger to themselves. Family members may grieve the person who was, even as they love the person who is. This creates a peculiar kind of loss, Grief for someone who has not died but has changed. For the person with brain injury, establishing a coherent sense of identity that integrates past and present, losses and remaining strengths is crucial psychological work. Some adopt the identity of brain injury survivor, finding community and purpose in this label. Others resist it, not wanting to be defined by injury. Both approaches are valid. Identity is not singular, but multifaceted. One can be a brain injury survivor and also a parent, a friend, a worker, a hobbyist, a person with particular values and interests. The challenge is finding balance, acknowledging the impact of injury without letting it become the totality of identity. Narrative therapy approaches encourage people to tell their story, to create meaning from experience. The story is not, "My life ended when I had a brain injury," but something more complex. "I had a brain injury. It changed me. I lost some things and discovered others. I am still me, and also different. I am building a new life." For family members too, identity shifts are significant. A spouse becomes a caregiver. A parent continues parenting an adult child who needs more support than expected. A child takes on responsibilities for a parent. These role changes can be disorienting and grief-inducing. Support, counseling, and time help individuals and families navigate identity questions. There are no simple answers, no timeline for resolution. Identity after brain injury is not recovered but reconstructed, an ongoing process rather than a destination. Accepting ambiguity, holding contradictions, and allowing identity to evolve gradually supports this difficult but essential work. Relationships, tested and transformed. Brain injury tests relationships profoundly. Marriages face enormous strain. The person who was a partner in all aspects of life may now need care, may have changed personality, may be unable to work or contribute as before. Intimacy, both emotional and physical, may be affected. Some relationships deepen through adversity. Partners discovering reserves of love and commitment they did not know they possessed. Others fracture under the strain. Divorce rates are higher after brain injury, a painful but understandable reality given the challenges. There is no shame in acknowledging that a relationship cannot withstand such stress. Some people remain committed out of obligation or guilt, leading to resentment. Others genuinely find new ways to relate, accepting changes, and building a different but still meaningful partnership. Relationships with children are affected too. A parent with brain injury may be unable to provide the same care and guidance. Children may take on caregiving roles, a reversal that can be both maturing and burdensome. Explaining brain injury to children requires honesty appropriate to their developmental level. Young children need reassurance that the parent still loves them, even if behavior has changed. Older children and teenagers may struggle with embarrassment, anger, or grief. They need support from other adults, information about brain injury, and permission to have their own feelings. Friendships often change. Some friends remain steadfast. Others drift away, uncomfortable with disability, or simply unable to maintain the relationship when the person with brain injury cannot participate in former shared activities. New friendships may form, particularly with others who have experienced brain injury or disability. These relationships carry understanding that others cannot provide. Rebuilding social connections takes time and effort. Social skills training, supported socialization opportunities, and gradually increasing social contact all help. The goal is not necessarily to return to the same social network, but to have meaningful connections, people who provide support, companionship, and belonging. Relationships after brain injury may look different, but they can still be deep, authentic, and sustaining. Love, connection, and shared humanity persist through enormous challenges. The sibling experience. When brain injury happens to a child or adolescent, siblings face a unique set of challenges. Suddenly, their brother or sister is in the hospital. Parents are distracted, frightened, and exhausted. The home routine is disrupted. The sibling may be sent to stay with relatives or friends. When the injured child returns home, they may look different, act different, need extensive care. Parental attention flows disproportionately to the injured child. Therapy appointments, medical crises, and behavioral challenges dominate family life. The uninjured siblings may feel neglected, guilty for feeling jealous, confused about what happened, and worried about their siblings' recovery. Age affects how siblings understand and cope. Young children may fear they caused the injury or believe it's contagious. They may regress in behavior, seeking reassurance. School-age children may feel embarrassed by their siblings' differences or angry about the attention imbalance. Adolescents may feel burdened by increased responsibilities or resentful about how brain injury affects the whole family. All siblings need honest, age-appropriate information about the injury. They need reassurance that the injury was not their fault and that their feelings are normal. They need individual time with parents. They need outlets to express their feelings without guilt. They need normalcy, maintaining routines, activities, and friendships as much as possible. Siblings can also experience positive outcomes from the experience. Many develop increased empathy, compassion, and resilience. They may pursue careers in healthcare or advocacy. They form deep bonds with their brother or sister, becoming advocates and supports throughout life. Family therapy can help the entire family adjust to changed dynamics. Sibling support groups connect children with others in similar situations. Parents must balance the tremendous demands of caring for a child with brain injury with the ongoing needs of all their children. It is an impossible balance to strike perfectly, but awareness and effort matter. Siblings deserve acknowledgement that their lives too have been affected. Their feelings matter, and they remain important members of the family. The science of consciousness brain injury forces us to confront one of science's deepest mysteries: consciousness. What is the relationship between the physical brain and the subjective experience of awareness? Philosophers have debated mind-body dualism for millennia. Does consciousness arise from brain activity or exist independently? Brain injury research strongly suggests that consciousness depends on brain function. Damage to specific brain regions disrupts consciousness in predictable ways. Injury to the brainstem causes coma. Widespread cortical damage causes vegetative states. Yet the precise mechanisms by which neural activity gives rise to subjective experience remain unknown. Recent research has revealed surprising complexity. Some patients, diagnosed as unconscious, show brain activity, suggesting awareness when asked to imagine specific tasks. Their motor cortex activates when asked to imagine playing tennis. Their parahippocampal cortex activates when asked to imagine navigating their home. They are conscious, but unable to demonstrate it through movement. This discovery has profound implications for ethics, treatment decisions, and our understanding of consciousness itself. It suggests that consciousness is not all or nothing, but exists on a spectrum. It raises the possibility that some patients retain awareness while appearing completely unresponsive. Advanced brain imaging and electrophysiology are revealing signatures of consciousness, patterns of brain connectivity, complexity of neural signals, and integration of information across brain regions. These objective measures may eventually allow detection of consciousness independent of behavioral responses. They may guide prognosis, inform treatment, and ensure that conscious, patients are not misidentified as unconscious. The neuroscience of consciousness is rapidly evolving, driven partly by the urgent clinical need to assess consciousness in brain-injured patients. Each discovery brings us closer to understanding the relationship between brain and mind, one of humanity's most enduring questions. The long arc of recovery. Recovery timelines after brain injury vary enormously. Some people recover quickly, especially after mild injuries. Others improve gradually over years. Still others reach a plateau beyond which further recovery is unlikely. Healthcare providers speak of the first 3 to 6 months as a period of rapid improvement, with gains continuing more slowly for a year or two. After that, significant new recovery is less common. Yet many people report continued improvement years after injury, particularly in adaptation and quality of life, if not in raw function. What explains these different patterns? Severity of injury matters most. Mild injuries generally heal more completely than severe ones. Age affects recovery, with children and young adults typically recovering better than older adults. Pre-injury health and cognitive reserve influence outcomes. Education, intelligence, and a cognitively stimulating lifestyle may provide buffer, allowing better compensation for injury. Genetics likely play a role, though specific factors are not well understood. Social support profoundly affects outcomes. People with strong family and community support, adequate financial resources, and access to services fare better. Psychological factors like motivation, coping style, and mental health influence both recovery and adaptation. The intensity and quality of rehabilitation matter. More therapy generally leads to better outcomes, at least up to a point. Evidence-based treatments work better than unproven approaches. But beyond these general patterns, individual variation is enormous. Prognosis for any specific individual remains uncertain, especially early after injury. This uncertainty is difficult to bear, but also leaves room for hope. The person who defies expectations, who recovers beyond what seemed possible, is not mythical, but real. Such outcomes cannot be predicted or promised, but neither can they be ruled out. The long arc of recovery bends toward improvement for many, though the endpoint and timeline remain individually variable. Windows into the brain. Understanding brain injury requires seeing inside the skull, visualizing the damage, tracking changes over time. Multiple imaging technologies make this possible. CT scans use X-rays to create cross-sectional images of the brain. They are quick, widely available, and excellent for detecting bleeding, fractures, and swelling in acute injury. MRI scans use magnetic fields and radio waves to create detailed images with better resolution than CT, particularly for soft tissue. They can detect smaller injuries, diffuse axonal injury, and subtle changes, invisible on CT. However, they take longer and are not compatible with some medical devices. Functional MRI measures brain activity by detecting changes in blood flow. Active brain regions require more oxygen, delivered by increased blood flow. fMRI reveals which brain areas activate during specific tasks or states. It has been used to detect consciousness in seemingly unresponsive patients and to study how the brain reorganizes after injury. PET scans use radioactive tracers to measure metabolic activity, blood flow, or specific molecular processes in the brain. They can reveal areas of decreased function, even when structure looks normal. Newer techniques like diffusion tensor imaging visualize white matter tracts, the bundles of axons connecting different brain regions. This helps assess diffuse axonal injury. Magnetoencephalography, MEG, and electroencephalography, EEG, measure the brain's electrical activity directly. EEG which places electrodes on the scalp, has been used for decades to diagnose seizures and assess consciousness. MEG, which measures magnetic fields produced by electrical activity, offers better spatial resolution. These technologies are not just diagnostic tools, but research instruments revealing how the brain functions and dysfunctions. Each advance in imaging brings clearer views of injury and recovery, though we are still far from seeing everything. The brain's complexity means that even the most advanced imaging captures only part of the picture. Much remains invisible, requiring inference from behavior, symptoms, and clinical course. Artificial intelligence and brain injury. Artificial intelligence is beginning to transform brain injury care in multiple ways. Machine learning algorithms can analyze brain images more quickly and sometimes more accurately than human radiologists. Detecting subtle abnormalities that might be missed, AI can predict outcomes by analyzing large datasets of patient characteristics, imaging findings, and recovery patterns, potentially guiding treatment decisions and providing more accurate prognoses. Natural language processing analyzes clinical notes to identify patients at risk for complications or those who might benefit from specific interventions. AI-powered rehabilitation tools adapt to patient performance, automatically adjusting difficulty to provide optimal challenge. Chatbots and virtual assistants provide information, answer questions, and offer support 24/7, extending the reach of clinical teams. AI algorithms analyze speech patterns to detect subtle cognitive changes or mood disturbances. Computer vision systems monitor patients, detecting falls or concerning behaviors. Brain-computer interfaces use AI to decode neural signals, translating thoughts into actions. These technologies are in various stages of development, from experimental to clinically implemented. As with all AI applications in healthcare, important questions arise about accuracy, bias, privacy, and the appropriate role of algorithms in human care. AI is a tool, not a replacement for human judgment, compassion, and relationship. It can augment clinical expertise, but not substitute for it. The best approach integrates AI's analytical capabilities with human understanding of context, values, and meaning. In brain injury care, where uncertainty is high and individual variation enormous, AI may help identify patterns and possibilities, but humans must interpret these in light of individual circumstances. The goal is not AI replacing clinicians, but AI enabling better, more personalized care. The future likely holds increasing integration of AI into all aspects of brain injury prevention, diagnosis, treatment, and rehabilitation, ideally improving outcomes while maintaining the essential human elements of care. Global perspectives. Brain injury is a global challenge, but resources and approaches vary enormously across countries and regions. In high-income nations, sophisticated trauma systems, advanced imaging, neurosurgery, and comprehensive rehabilitation may be available, though not always accessible to all, due to cost or geography. In low and middle-income countries, basic neurosurgical capacity may be limited or absent. Imaging may be unavailable. Rehabilitation services may not exist. Brain injury outcomes are consequently far worse in resource-limited settings. This health inequity reflects broader patterns of global inequality in healthcare, infrastructure, and resources. Efforts to address these disparities include training local healthcare providers in brain injury care, developing low-cost technologies appropriate for resource-limited settings, and implementing prevention programs targeting the leading causes of brain injury in each region. The WHO recognizes brain injury as a major public health problem, and provides guidelines and support for prevention and care. Cultural factors also shape brain injury experiences. Understanding of disability, family, structures, gender roles, and spiritual beliefs influence how brain injury is interpreted and managed. In some cultures, disability carries stigma, leading to isolation and lack of support. In others, extended family networks provide care that might fall to professional services elsewhere. Western individualistic approaches to rehabilitation may not fit collectivist cultures where family and community are central. Treatment models developed in wealthy Western nations may not translate directly to other contexts. Effective global brain injury care requires both universal evidence-based practices and cultural sensitivity, adapting approaches to local contexts while working to reduce fundamental inequities in access to care. Every person deserves the best possible care after brain injury, regardless of where they were born or live. Progress toward this goal requires global cooperation, resource sharing, and commitment to health equity as a fundamental human right. Environmental enrichment research with animals has revealed that environmental enrichment, exposure to stimulating complex environments, with opportunities for physical activity, social interaction, and cognitive challenge, promotes brain health and enhances recovery after injury. Enriched environments increase neuroplasticity, neurogenesis in certain brain regions, and improve cognitive function. While human research is more limited, the principles likely apply. Monotonous, understimulating environments may hinder recovery. Rich, varied environments that engage multiple senses and abilities may promote healing and adaptation. What does this mean practically? Rehabilitation environments should be stimulating, not sterile. Music, art, plants, varied activities, and social interaction all enrich the environment. For people living at home, getting out into the community, maintaining hobbies and interests, staying socially connected, and engaging in enjoyable activities all constitute environmental enrichment. Physical exercise is particularly important. It promotes neuroplasticity, improves mood, and enhances cognitive function. Cognitive stimulation through reading, puzzles, learning new skills, or engaging conversations challenges the brain to adapt and grow. Social interaction provides emotional support and cognitive stimulation. The opposite of enrichment is sensory deprivation and social isolation, which can worsen outcomes. Being confined to a bed or room with nothing to do, no visitors, no stimulation represents the worst possible environment for recovery. This reality has implications for how we design hospitals, rehabilitation facilities, and long-term care settings. It also emphasizes the importance of getting people back into their homes and communities as quickly as possible, where life's natural richness provides ongoing stimulation. Recovery happens not just in therapy sessions, but throughout the day, in every interaction, activity, and experience. Making those experiences as rich and positive as possible supports healing. And so we rest. Dear listener, we have journeyed together through the landscape of brain injury, exploring its many forms and faces. We have seen the brain in all its fragile magnificence, capable of remarkable achievements, yet vulnerable to forces both sudden and subtle. We have walked with those who have experienced injury, through the initial trauma, the uncertain recovery, the long adaptation, and the building of new lives. We have met the families who stand beside them, the caregivers who sustain them, the professionals who treat them, and the researchers who seek to understand and prevent these injuries. We have learned that brain injury is not a single thing, but a spectrum, from mild concussion to devastating trauma, from the visible to the invisible, from the temporary to the permanent. We have seen that recovery is possible, but not guaranteed. that the brain's plasticity offers hope, while its complexity humbles us. We have recognized that living with brain injury is not simply a medical challenge, but a human one, involving questions of identity, meaning, relationship, and quality of life. We have acknowledged that much remains unknown, that uncertainty pervades prognosis and treatment, but that knowledge grows and hope persists. As you lie here now, letting these words drift over you like gentle waves, perhaps you feel a deeper appreciation for the 3 pounds of tissue resting in your own skull. This organ that allows you to hear these words, to understand their meaning, to feel whatever emotions they evoke, to remember or forget them as you drift towards sleep. The brain that maintains your breathing as you relax, that will guide you into dreams, that will carry you through tomorrow and all the tomorrows beyond. It is both ordinary, present in every human, and extraordinary, enabling all that makes us human. For those touched by brain injury, may these words bring understanding, comfort, and a sense of being seen. May they validate the struggles that often go unrecognized and honor the resilience that emerges in response. May they remind you that though the journey is difficult, you do not walk it alone. For those who care for someone with brain injury, may these words deepen your understanding and appreciation for both the challenges faced and the strength required. May they encourage you to care for yourself, even as you care for another. For those who work in brain injury care, may these words remind you of the profound impact of your work, the difference made by skilled, compassionate treatment. May they sustain you through the inevitable difficulties and uncertainties of this demanding field. And for all listeners, may this exploration deepen your awe at the brain's complexity, your gratitude for its functioning, and your compassion for those whose brains have been injured. May it inspire you to protect your own brain through safe practices, to support research and services for brain injury, and to build a society more inclusive of people with disabilities. Now, as your breath slows and deepens, as your muscles relax, as thoughts begin to fade into the softness of approaching sleep, let go of all that has been said. The details do not need to be remembered. If you are still awake, you need not try to retain any specific information. Simply let it all drift away, like clouds across a twilight sky. What remains is something deeper than facts, an awareness of fragility and strength, of loss and resilience, of the preciousness of consciousness itself. Your brain is working even now as you rest, consolidating memories, processing emotions, repairing and restoring itself in ways we are only beginning to understand. Sleep is when the brain does some of its most important healing work, clearing metabolic waste, strengthening important neural connections, preparing for tomorrow. So let sleep come. Let your marvelous, mysterious, irreplaceable brain have the rest it needs. Let all questions fade, all concerns drift away. Whether you have been touched by brain injury or not, whether these words have brought understanding or simply filled the time as you settled into rest, you are here now, in this moment, breathing, aware, alive, and that itself is something to marvel at, something precious. The fact that billions of neurons, firing in intricate patterns, create the experience of you, of consciousness, of being present in this moment. It is extraordinary. It is ordinary. It is the quiet miracle of existence. So rest now, deeply, peacefully, completely. Let the darkness hold you gently. Let consciousness fade into sleep, knowing that it will return in time, refreshed and renewed. Close your eyes, breathe slowly, and drift into the healing silence of sleep. All is well. The journey continues tomorrow. For now, there is only rest, only peace, only the gentle descent into dreams. Good night.